Hi, this is a lecture on schizophrenia spectrum disorders and other psychotic disorders. This is chapter 17 in your book. Schizophrenia means split mind. The diagnosis of schizophrenia is often misinterpreted as a split personality, but as you know, a split personality is actually dissociative identity disorder. Schizophrenia is potentially a devastating brain disorder, and it affects thinking, language, emotions, social behavior, and the ability to perceive reality accurately. Schizophrenia is a devastating brain disease that targets young people in their teens and early 20s at the beginning of their productive lives. Schizophrenia spectrum disorders are a group of psychotic disorders. Remember that psychosis is not a diagnosis, but is a symptom. Psychosis refers to the total inability to recognize reality, and it includes delusions and hallucinations. Schizophrenia almost always occurs with some other psychiatric illness, such as substance abuse disorders, anxiety, depression, suicide, physical health illness, and polydipsia. Etiology. There are genetic factors in schizophrenia. It most likely occurs as a result of a combination of inherited genetic factors and extreme non-genetic factors, such as a viral infection, birth injury, or nutritional factors. These may alter the structure of the brain and alter the naturally occurring neurotransmitters and disrupt those circuits. Neurobiologic theories includes a dopamine hypothesis, which for a long time was the most widely accepted explanation for the biochemical pathophysiology in schizophrenia. The dopamine hypothesis concludes that there is hyperactivity of the neurotransmitter dopamine in the limbic region of the brain. With the development of atypical antipsychotic drugs that block serotonin, it became apparent that serotonin may also play a role in causing some of the symptoms associated with schizophrenia. There is also a possible role of glutamate in the pathophysiology of schizophrenia. Numerous brain imaging techniques such as CT, MRI, functional MRI, and PET scans provide substantial evidence that some people with schizophrenia have structural brain abnormalities. For example, MRI and CTs demonstrate lower brain volume, larger lateral and third ventricles, atrophy in the frontal lobe. Sorry about that. PET scans show a low rate of blood flow and glucose metabolism in the frontal lobes. So there are physical as well as psychological aspects to schizophrenia. Psychologic and environmental factors include prenatal stressors, so pregnancy and complication may cause some kind of damage to the reality processing centers. Psychologic stressors may include development and family stress. Environmental stressors such as social adversity, chronic poverty, and growing up in a high crime area or in a foreign culture can all be risk factors or factors to the development of schizophrenia. The course of the disorder. This is on page 308. The pre-psychotic phase, or the prodromal phase, includes signs and symptoms that precede the acute, fully manifested signs and symptoms. Prodromal symptoms occur in 80 to 90% of people with schizophrenia before the emergence of frank psychosis. During the prodromal phase, early symptoms include social withdrawal and deterioration in function and depressive mood. This is followed by perceptual disturbances, magical thinking, peculiar behavior. The symptoms may appear a month to a year before the first psychotic episode. Late in the phase, words and phrases become indecipherable. Often, the person with a history of schizophrenia reveals that during adolescence, the person was withdrawn from others, lonely, perhaps depressed, and expressed vague or unrealistic plans regarding the future. During the acute phase, the patient has periods of florid positive symptoms, more fully developed and flagrant, such as hallucinations and delusions, as well as the negative symptoms, including apathy and withdrawal. During the stabilization phase, the patient has acute symptoms decreasing in their severity, especially the positive symptoms. And then during phase 3, the maintenance phase, the symptoms are in remission, although there might be milder persistent symptoms. Here's our case study for schizophrenia. Min was a quiet child. During adolescence, she participated in group activities. Shortly after her 17th birthday, she began to seclude herself in her room and listen to music for hours. She began to miss school frequently, stating that her future was in music, although she neither played an instrument nor sang. Within 3 weeks, she refused to attend school. She talks only of her music. Her parents speak little English and do not know what to do. So think about what are some of the symptoms there, and think about what phase is Min in. She is clearly entering the prodromal phase of schizophrenia. So think about what symptoms we would expect during the prodromal phase. Those symptoms are listed on page 308 in your book. Now, there are 4 main symptom groups in schizophrenia. These are also on page 308 in your book, box 17-2. Positive symptoms are psychotic symptoms, and they are the most obviously schizophrenic symptoms. These are the symptoms that add to the person's reality. These are things like delusions and hallucinations and perceptions that are not based on reality. Negative symptoms are things that withdraw from the person's reality or take away from their reality. The patient has poverty of thought, less motivation, the inability to experience pleasure or joy. And then the third one is cognitive symptoms, including the inability to understand and process information, trouble focusing, and problems with their working memory. Now, the positive, negative, and cognitive symptoms are considered the cardinal symptoms of schizophrenia. So if the patient has those 3, that's pretty classic symptomology of schizophrenia. Then there are also affective symptoms, which is how they present. The grossly disorganized or catatonic behaviors, and then the characteristic isolated, alienated behaviors of the person. So here they are. Here are all of those symptoms. The positive, cognitive, negative, and affective. All of these together alter the individual's ability to work, their interpersonal relationships, their ability to care for themselves, their functioning, and their overall quality of life. Some nursing diagnoses for the person with schizophrenia includes disturbed sensory perception, risk for self-directed violence, risk for other-directed violence, disturbed thought processes, impaired verbal communication. Diagnoses for the negative symptoms may include social isolation, impaired social interaction, risk for loneliness, chronic low self-esteem, risk for violence, ineffective coping, self-care deficit, and constipation. Back to Min. Min is taken to the emergency department by her parents. She has not showered in 4 days, refuses food, stating that it's poisoned, and sits in her darkened room with music blaring. The psychiatrist tells Min's parents she needs to be observed. Over several days, she is admitted to the psychiatric unit. It is likely Min is entering the acute phase of schizophrenia. Think about other possibilities or precipitators of psychotic symptoms. We talked about some things that may contribute to the development of schizophrenia, but think about some things that she may have gone through that may have triggered this. And then why do you think is the primary reason that she should be admitted? Alterations in thinking. This includes delusions, concrete thinking, impaired reality testing. So impaired reality testing means that the person is not able to differentiate between what is real, what is reality, and what is not. Delusions then are false beliefs that cannot be corrected by reasoning. So for example, I posted a video that showed a female patient in an interview during a psychotic episode, and she continued to perseverate and fixate on a plastic bag that Jesus was moving. So that is her false belief, and if we try to reason with her, she will believe that that is true and that that truly happened. And then concrete thinking, they have impaired ability to think in the abstract. Alterations in speech. Oftentimes patients with schizophrenia have loose associations, which means that their thinking is haphazard or illogical and confused. So for example, the lady that was in the interview again was talking about Jesus with the paper bag. So there was an association between Jesus having a plastic bag and that meaning that someone had to do something with a gun. So that there's that looseness of associations. Another common one is there at the neologisms, which are made-up words that have special meanings. For example, the book talks about mannerologies of his hospitality, which children and creative writers often make up their own words, but these words are imaginative, constructive, and adaptive, and they represent a disruption in their thought process. Clang associations is meaningless rhyming of words. So the patient may have rhyming just because the book mentions on the track, have a Big Mac or get the sack. Rhyming is more important than the meaning of the speech. And then word salad is meaningless to the listener and perhaps to the speaker as well. It may have a string of neologisms. For example, the book says, I sang out for my mother, for this to hell I went, how long is road? So although they're able to articulate and say words that have meanings, they, as a sentence, don't make any sense. It's just a salad of words. Patients with schizophrenia also have echolalia, which is a pathologic repeating of another person's word. So, for example, you may ask them, how are you feeling today? And they will repeat the word feeling, 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 feeling. And then echopraxia is mimicking the movements of another person. And both of those, echolalia and echopraxia, are common in patients who have catatonia. Alterations in perception are seen in schizophrenia, which includes depersonalization that we talked about when we talked about personality disorders and identity disorders. It's the non-specific feeling that a person has lost his or her identity, that their self is different or unreal. Patients with schizophrenia also have hallucinations, especially auditory hallucinations. Hallucinations, by definition, are sensory perceptions for which there is no external stimulus. So the patient may hear voices that are very vivid and clear, with the full force and impact of a normal perception. The most common type is auditory, and then a subtype of auditory hallucination is a command hallucination, which is directing or commanding the person to do something. I had posted a news link about a little 12-year-old girl in Elkhart who murdered her stepmother and set the house on fire, and she was experiencing command hallucinations. So if you have a chance, maybe you can look that up. I saw just another update on her today, actually, that said that there was a clown who was commanding her to do these things. Command hallucinations are scary for the patient, and they may signal a psychiatric emergency. Patients who can give an identity to the hallucinated voice are at a somewhat greater risk of compliance with the hallucinated command than those who cannot give an identity to the command. Another alteration in perception is illusion. An illusion, okay, so we have a delusion, which is a false thought. We have hallucinations, which is a false sensory perception, so a false sound or a false sight. Illusions then are when the patient sees something as something else. So for example, they may see a chair, but then they perceive that chair to be a person. So that's the difference between an illusion, delusion, and hallucination. These patients may also experience derealization, which is a false perception by a person that the environment has been changed. For example, they may feel that everything seems bigger or smaller, or familiar surroundings may suddenly seem strange and unfamiliar. Alterations in behavior, they may have bizarre behavior, extreme motor agitation. They may have stereotyped behavior, which are motor patterns that originally had meaning to the person. So for example, you may see them sweeping the floor or washing windows, but they're now mechanical and they lack purpose. They may have waxy flexibility. I'm going to see if this link will work here while I'm recording. This is another YouTube video that if it doesn't work here, it will work in the slides as you look at them. Which this is not even the correct link. Okay, so this is the interview that we looked at with the woman having looseness of association. She also has some word salad, neologisms. Okay, so this is not going to show me the waxy catatonia. So we will just look at that in the slides when you're on your own, the waxy flexibility. Okay, so let me find my, sorry. Okay, so waxy flexibility is just the patient is not necessarily stiff, but you can position them in a certain position. For example, lift their arm. And while they don't feel rigid or stiff, they'll hold that arm in that position indefinitely. Stupor is a state in which the catatonic patient is motionless for long periods and may even appear to be in a coma. Negativism is equivalent to resistance. The patient does the opposite of what he or she is told to do. And then automatic obedience is just the opposite of that. It's performance by a catatonic patient of all simple commands in robot fashion. The patient has impulse control that may result in agitated behaviors, such as abruptly grabbing the TV remote control and changing channels. Okay, so looking back at Min, she's now 3 years after her first hospital admission, and she's now diagnosed with schizophrenia and has experienced several acute episodes. She continues to live with her parents who have limited income, and she's applying for Medicaid. So how has this diagnosis altered her life and impacted her family? Put yourself in her shoes and think about the stigma that's associated with schizophrenia. Remember that schizophrenia is a severe mental illness, and a large percentage of the homeless population have the diagnosis of schizophrenia. So think about the impact that this diagnosis can have on patients. Also, remember that 20% of individuals who have been diagnosed with schizophrenia have a favorable outcome, and some have completely recovered after their psychotic break, but not very many. Another important thing to remember is that with each relapse of psychosis, there is an increase in the residual dysfunction. So if Min has already had several acute phases or acute psychotic events, she's having more and more residual dysfunction and deterioration. So what can we as nurses do to help patients cope with this disability, with this illness? Some nursing diagnoses are table 17-4 on page 317, and then treatment at the different phases of schizophrenia are in table 17-5 on page 319. So those are some important things for you to review. Communicating with a patient with schizophrenia is aimed at lowering the patient's anxiety. It's important for us to remain calm and non-judgmental. It's important to decrease their defensive patterns. We need to encourage participation in therapeutic and social events. We need to raise their feelings of self-worth and increase their medication compliance. If a patient is actively hallucinating, it's important that you try to understand what the voices are saying or telling the person to differentiate if they are command hallucinations or if they are telling the patient to commit suicide or homicide. You should approach the patient who is hallucinating in a non-threatening, non-judgmental manner. Usually if you walk up and ask a schizophrenic patient, "Are you hallucinating?" they're immediately going to feel defensive. I tend to start a different conversation with them. How are you today? Did you sleep well last night? Did you eat some breakfast today? And then nonchalantly bring up, have you heard any voices? Or have you seen anything that doesn't make any sense? Or seen things that you're not sure if they're real? And sometimes they are more willing to open up and be honest about that. It's thought usually when a person is hallucinating, they're experiencing anxiety, fear, loneliness, and low self-esteem. We should maintain eye contact with them when we can. A lot of times they are not willing to make eye contact. You should call the patient by name and speak simply and firmly, but in a louder voice than usual to differentiate your voice from those auditory hallucinations that they may be having. The book gives very good examples of how to speak to a patient who is actively hallucinating. Pharmacologic. Antipsychotic medications alleviate the symptoms of schizophrenia but cannot cure it. There is no cure for schizophrenia. Psychotic symptoms return with noncompliance. These drugs are effective in acute exacerbations of schizophrenia, as well as preventing or mitigating a relapse. Conventional or first-generation antipsychotics target the positive symptoms, whereas the atypicals or second-generation antipsychotics target both positive and negative symptoms. Remember, the atypical agents have fewer side effects, and they're also used to treat anxiety, depression, and decrease suicidal behavior in the schizophrenic. This is just a reminder. The first generation antipsychotics that target positive symptoms are listed here on this slide. And remember that the first generation antipsychotics carry a much greater risk of extrapyramidal symptoms, tardive dyskinesia, neuroleptic malignant syndrome, as well as agranulocytosis. These patients need to have regular blood work done, and obviously for a patient with a severe mental illness, compliance is an issue. Just a reminder to treat those extrapyramidal symptoms. We've talked about Benadryl, Cogentin, also Artane, Simitrel, and Akinetone or Biparidin. The second generation antipsychotics or atypical antipsychotics are listed here for your review. Some disadvantages of these include weight gain, dyslipidemia, altered glucose, which carries with it a risk of diabetes, hypertension, atherosclerosis, and an increase in heart disease. Also remember that the atypicals are more expensive than conventional antipsychotics, and some insurances may not cover them. If the patient is on Medicaid, we may need to get those approved before the patient is prescribed those drugs. And then we have the adjuncts. So they may be on an antipsychotic and an adjunct, such as antidepressants, lithium, benzodiazepines, or clonazepam. Other psychiatric disorders, there's a nice table in your book, box 17-1 on page 305, that lists the other psychotic disorders. You should read through those and be familiar with them. Essentially, the treatment is the same, with the exception of substance or medication-induced psychotic disorder. If the patient is experiencing a psychotic disorder due to intoxication of the substance or withdrawal, or if there's a medical cause for the psychosis, that will be treated. The underlying condition will be treated. Otherwise, they're all treated with with the antipsychotics that we talked about in this chapter and back earlier in the semester. So that's the end of this presentation. If you have any questions, please just get in touch with me, and you can email me or send me a text or give me a call, and I'll be happy to answer any questions you have.